Hello, everyone. Thank you so much for joining our event. My name is Suzanne Hartzell, and I'm a veterinarian for SIVA and one of the presenters for today's event. Along with our moderators, Alessia and Alexandra, and many other SIVA colleagues who join us from all over the world, we would like to extend to you a very warm welcome. To begin, I would like to cover a few details about using the BlueJeans video conferencing platform. You will notice several icons on the upper right-hand corner of your screen. If you do not see these icons, simply minimize your screen by pulling your cursor to the lower left-hand side and click the arrows pointing toward each other. The four icons at the top right include a participant roster, a moderator chat icon, a polling icon which will not be used today, and most importantly, a Q&A icon. If you have a question or comment for Dr. Atkins during the presentation, please click the Q&A button and type your question. The Q&A is seen by moderators, presenters, and attendees. If you have technical issues or would like to communicate with one of the moderators, please click the moderator chat button and type in your question or comment. Our speaker likely needs no introduction for this audience. I'm very pleased to introduce to you guys Clarke Atkins. He is the Jane Lewis Seeks Distinguished Professor of Companion Animal Medicine Emeritus at North Carolina State University, as well as the Norden Outstanding Teacher Award recipient. Board certified by the ACVIM in both cardiology and medicine, Dr. Atkins has served on 4 ACVIM or International Consensus Committees on systemic hypertension, canine mitral valve disease, and cardiorenal syndrome, as well as received the Honorary Member Award from the American Heartworm Society in 2019. His research involves canine and feline heartworm disease and treatment of cardiovascular disease in dogs, cats, and horses. He has over 150 publications and has provided well over 1,000 hours of continuing education in the U.S. and many countries around the world. Thankfully, Dr. Atkins continues to be active speaking and carrying out clinically oriented research in his retirement. During the live Q&A, Dr. Atkins will actually be joined by Dr. Melissa Kaufman, the Pharmaceutical Development Manager here at SIVA. In addition, we're joined by our biostatisticians, Spark Fang and Tomas Blondell. All of our guests have been an integral part of the BEST study, and we are very grateful to have them all with us today. Thank you so much for joining, and I hope you enjoy the presentation.
So, Dr. Kaufman and I will present these data. The BEST trial compares CARDALIS, which is a fixed combination of benazepril and spironolactone with benazepril itself. And as you can see, this is a clinical study of ACVIM stage C dogs, which is important because this drug has been long appreciated in Europe, but it's never been tested against this severity of heart failure, and nor in this largest study. In addition, this is a pivotal efficacy study for the FDA, and that's very important, and I would like to congratulate Stephen not only on completing this study, but also on achieving that approval. When we talk about spironolactone, we think of mineralocorticoid receptor antagonists, of course, MRAs, and this concept was first put forth by an idol of mine, Dr. Bertram Pitt, whose photo you see here to the right of the bound heart. Dr. Pitt conceptualized the idea of aldosterone escape. He called it, later it became breakthrough in 1995, and then published the Rawls trial, which was a landmark study in human cardiology. Dr. Pitt is a grand person in the profession, and the dog on the left is the dog that I believe that if he had a dog, and I don't know if he does, that Dr. Pitt would own. On the right, what we see is the the first study I saw in clinical times of an effect of aldosterone breakthrough. This was the Resolve trial published in '99, same year as the Rawls trial. And in this study, there are no numbers on this graph, but you see that once an ACE inhibitor is started, angiotensin II and aldosterone levels fall, but then somewhere between 17 and 43 weeks start to rise back up or escape or break through. This has been really not very well characterized in human medicine. The best data we have is a meta-analysis published in 2007 by Bombeck and Klemmer, looking at about 500 patients from many studies. And what they found is that aldosterone breakthrough occurs in 10% of the population at 6 months, and then around 38% of the population at 1 year. If you would, please keep in mind that 38% number. What you'll see is that shows to be true in animal studies and also in the degree of benefit that's shown in clinical studies in both man and animals, suggesting to me at least that much of the benefits we get from spironolactone or eplerenone, the second generation mineralocorticoid receptor antagonist, is due to its effect on aldosterone breakthrough. There are other things that are beneficial, but that's probably the major factor. Here are a family of studies carried out at NC State, and I'd just like to mention the co-investigators for these studies. They include Dr. Darcy Aden, Marisa Ames, Amanda Coleman, Yoko Fuji, Andrea Lantis, and her name is now Erickson de Rezende, Peg Sayre, and Will Rausch. And some time ago, back in the late 90s, we began to look at this, and what we showed was that one could use urinary aldosterone to creatinine level to estimate total aldosterone production in 24 hours. We chose to use, because we don't make animals sick at NC State, at least in cardiology, to use a model of heart failure. And we did that by taking normal dogs and giving them furosemide at a standard dosage. Here you see a control group of dogs, and then what was incredibly consistent is a 2.5 to 3-fold increase in aldosterone secretion on, in this case, day 4, with 2 mg per kg twice a day, so a regular dosage. We continued to use that model in multiple studies, and they're shown for you here on the top row, these 3, which I'm not going to go to in any detail, but I want to tell you that with furosemide or amlodipine as a stimulant, we studied both enalapril and enalapril. So both of the major drugs on the market, we studied them at low dose, at high dose, and you can see in the end study also with pimobendan. Typically they were put on Lasix, and then the ACE inhibitor was added on. In the case in the middle, it was added on at day 10, and we followed them out to day 17. But you can see that in every one of these, circled in red here, aldosterone breakthrough occurred. Here, the non-breakthrough dogs are circled in blue, and here again in red. And so what you see is roughly 75% or 50 to 75% of these dogs broke through. This occurred, if you drop to the bottom row of slides, this occurred despite suppression of ACE activity. So here we see the same dogs as in the furosemide study above, in which here's baseline. This is with furosemide alone in gray, and furosemide plus benazepril concurrently in red. And we see then at day 1 that ACE activity is significantly and dramatically reduced, even more so on day 3, and stays about the same at day 7. However, when we drop down to the bottom row on that slide, on that graph, we see that looking at RAS activity, or urinary aldosterone to creatinine ratio, that here we are at baseline. We would not expect this to be suppressed with Lasix, and indeed it's markedly increased. it also is with Lasix and benazepril. And you can see at nowhere along the way, despite substantial suppression of ACE activity, did we have significant suppression of RAS activity. Now, some individual dogs suppressed, but the means did not. Finally, in the middle slide there, Dr. Marisa Ames and I looked at clinical cases in the first group of dogs here. In A, these dogs are all in heart failure on furosemide and an ACE inhibitor. And what you see is that depending on which cutoff points you use, but at least 33% of them have broken through. Interestingly, dogs not receiving Lasix, meaning dogs that had disease but were not yet in heart failure, so weren't on Lasix, had a substantial percentage breakthrough as well, a little bit higher, more around 40%. And then lastly, we see that this phenomenon of aldosterone breakthrough while it's been studied most in ACE inhibitors, is not native to just them, and it occurs with ARBs as well. So in this study of telmisartan in dogs, we see that in dogs stimulated with amlodipine, that we had aldosterone breakthrough, as shown here, in 2 of 5 or 40%. So in summary, with Lasix provocation, aldosterone breakthrough occurs with enalapril and benazepril in over 50% in our model, despite ACE suppression. It's found in about a third of clinical cases, and it occurs early. This occurs typically on day 1, and that is different than what is known in human medicine. I'm not sure that it's different than what actually happens in human medicine. So just to complete this then, we'll look at the placebo-controlled double-blind trials, which looked at MRAs, both spironolactone and eplerenone in human and veterinary medicine. And first is the Rawls trial, as I mentioned, 1999, Bertram Pitt. Spironolactone added to standard therapy gave a significant improvement of about a third to the survival of severely ill heart failure patients. A few years later, the Efficacy trial looked at eplerenone, and again in mortality, this is now going upward in mortality as opposed to survival. We see significant benefit, a little less, about 25%, but please note how early, based on the yellow arrow, note how early these curves separate. The effect occurs early. This is shown again in the Emphasis trial in 2011, looking at eplerenone in patients with heart failure after a myocardial infarct and moderate heart failure. And then finally, we have the Bernet study. Dr. Bernet did this study in 2010, and she compared in a placebo-controlled double-blind trial spironolactone, the trade name Prilactone in Europe, versus control population with standard therapy, and found a significant, highly significant benefit in these dogs. So we see it with late severe heart failure, acute MI and heart failure, MI and myocardial 2 heart failure, and we see early separation in each of those. Again, it's also seen with Prilactone in ISEC stage 2 heart failure. The average percentage of all these benefit was 33%. So in summary then of the BEST trial, ACVM stage C, as I mentioned, this was a study carried out in the United States. To me, that's really relevant. Although there was one previous RAS suppressant drug approved for use in dogs in this country, it was no longer marketed, and this is the first study of a RAS suppressant drug in dogs in some time. It's a multi-center, double-blind, randomized, good clinical practices field study, which also was FDA, so it was highly supervised. It's the best kind of study that we can do. 27 centers in the US, and it was carried out from 2012 through mid-2016 with a follow-up period of 12 months. The objective was to compare the clinical effectiveness and safety of CARDALIS, the fixed dosage benazepril spironolactone combination given once daily versus control population which received benazepril at the same dosage. The last point I want to make is that 569 dogs were enrolled in this trial. That is the largest veterinary cardiac study done to date. So I'm going to turn it over now for materials and methods to Dr. Kaufman. I'd just like to say that Melissa joined the company about 4 years ago at a time when this study was just winding down. So she's had this data set, she's worked with it, she's worked with the FDA in their recommendations, and she's a great resource. Go ahead, please, Dr. Kaufman.
Thank you, Dr. Atkins. Okay, so yeah, I'll present the materials and methods briefly here. So inclusion criteria for this study was based off of clinical, radiographic, and echocardiographic parameters. Clinically, the dogs had to have moderate to severe mitral regurgitation. They had to be larger than 2.5 kilograms, have a left-sided grade 3 out of 6 or greater murmur, and have signs of exercise intolerance and/or dyspnea. And that had to be within the previous 10 days or at day 0. Exercise intolerance and dyspnea was scored on a scale of 0 to 3. So a score of 1 at day 0 or within the previous 10 days was required. They also had to have heart enlargement and pulmonary edema on thoracic radiographs with evidence of cardiomegaly. The pulmonary edema could be at day 0 or within the prior 10 days. Pulmonary edema was scored on a scale of 0 to 4, and it had to be greater than or equal to 2 within the 10 days before inclusion or at day 0. And finally, they had to have mitral valve disease on the echocardiogram, so typical valve lesions and evidence of moderate to severe mitral regurgitation. They were allowed some previous cardiac treatments prior to enrolling in the study. ACE inhibitors were allowed up to 30 days treatment prior to day 0, and other cardiac drugs were allowed up to 10 days treatment prior to day 0. Mostly the other cardiac drugs were required for stabilization of the heart failure. And you can see some of the ones listed here that were included on this study. The most important probably being the diuretics, largely furosemide. And furosemide was allowed within the 10 days prior to day 0. It was allowed oral and IV, but IV was only allowed for less than a 48-hour duration if needed. And it was mandatory to be receiving oral furosemide at day 0 at a dose less than 6 mg per kg. So we wanted these dogs to be stabilized, but not on long-term cardiac therapy. At day 0, as I already said, they had to have oral furosemide being prescribed. It could be either initiated at day 0 or continued from that 10 days prior. The investigators were allowed to increase or decrease this dose as they saw fit during the study, whether it be for a cough or increased resting respiratory rate, or if the dog had some azotemia. They were allowed to play with this dose as long as it didn't get higher than the 8 mg per kg per day. And if that happened, the dog was withdrawn for the study and considered to have met cardiac endpoint. There were a few cardiac meds that were allowed besides the furosemide, and mostly these were just for heart rate control. So digoxin and calcium channel blockers were allowed on the study. All other heart meds had to be stopped at day 0. If the dogs needed the cardiac meds, they needed to be withdrawn from the study. And finally, at day 0, dogs were tested for heartworm disease and, of course, screened for other heart diseases. And if either of these was present, they were not allowed to start the study. The tested treatments, as Dr. Atkins already mentioned, were the combination CARDALIS with benazepril and spironolactone versus benazepril. So this was a positively controlled study. Blinding was ensured by a treatment dispenser. So both the investigator and the client of the dog, or the owner of the dog, did not know what treatment the dogs were receiving. The doses are listed there, and due to the weight range of dose, there was a range given, and those are in the parentheses underneath. So benazepril was given in a range of 0.25 to 0.5 mg per kg, and spironolactone in a range of 2 to 4 mg per kg. So follow-up visits, we had follow-up visits first at day 7. This was to kind of screen dogs for early failure. And then day 30, day 90, day 180, day 270, and finally at day 360, which is when the primary efficacy criteria was determined, which was the percent of dogs that had met cardiac endpoint. We also looked at a number of secondary efficacy criteria, as well as, of course, adverse events and safety throughout the study period. Some of the secondary efficacy criteria we looked at were the clinical signs present throughout the study versus day 0, the quality of life versus day 0, and this was determined by a fetch score, which is owner completed. So this was the owner assessment of the quality of life. We also determined the percent of the animals that had reached the cardiac endpoint, not only at day 360, but at each visit, as well as the time to reach the cardiac endpoint and the time to cardiac death and euthanasia. And the definition of our endpoint included death due to cardiac disease or euthanasia due to cardiac disease. This includes sudden death. We can't always determine if that's cardiac or not. So for study purposes, it is determined that it will be cardiac. Also recurrence or worsening of pulmonary edema. This is determined on radiographs and the radiographic score. And this is regardless of the current doses of furosemide. Worsening of clinical signs and or new cardiac signs versus day 0 was also a reason to reach endpoint. And this included the need for therapy with the non-authorized cardiac drugs we discussed, and also the increase over the 8 mg/kg furosemide. And finally, if a dog presented with new cardiogenic ascites, that was also a reason to reach cardiac endpoint. So for now, I will turn it back over to Dr. Atkins to talk about the study population and the results.
Thanks, Melissa. The results I will follow here, I think they're pretty interesting. I also want to assure you that the little AV faux pas was all planned just to show this was spontaneous and live. Enrollment and efficacy population, I told you when this study was carried on, 27 centers, which are shown for you in the map. These were carried out by ACVIM diplomats, either cardiology mainly or internal medicine, 2 of the participants. There were 2 additional sites enrolled. They were enrolled no dogs. And the safety population, as we've already said, is 569 dogs. The efficacy population was 414 dogs. And I want to explain that to you because I think that this catches your eye and you will wonder why, as I did. These are the study populations. I have the blindfolded Lady of Justice here because I want to assure you, because I was assured, I found out that all these decisions were made while both the FDA and the CEVA scientists were blinded to the groups. In addition, all these things were done with the approval or at the insistence of the FDA. So she has the FDA looking over her shoulder. Started out with 569 dogs, and this was the safety population. So regardless of whether these dogs completed more than a week of the study, they were included in the safety population. There were, however, some exclusions from the study. 68 from CARDALIS, and as you can see, 87 from the Vonazepam group. And that difference was of interest to me. That gave us 414 dogs in the efficacy population. So that's what we're using for all of the, the primary endpoint, for example, and some of the secondary endpoints. There were, however, an additional 16 dogs in each group that were taken out by the FDA because as the medical records were perused, there were dogs in which the dosage went over 8 mg/kg for Lasix at some point. This was largely due to changes in body weight, owner error, veterinarian error, or a phone call in the middle of the night in which the dosage was increased until morning, the dog was okay, and they went on. The FDA felt that this did not affect the efficacy of the drug, but did not want to use it for the time to event population. So that reduced that to 382. Now, I promised you we would talk about why there was just, so many exclusions and why they were different between the groups. And I found this very interesting. The reasons are shown for you here. lack of compliance, non-cardiac disease adverse events, dosing documentation failure, exclusion of the whole site. I think the Animal Medical Center was one that was kicked out. Owner request, non-cardiac death or euthanasia, and late discovery of exclusion criteria. It turns out that those are all small individually and are the same between groups, number of dogs. The difference between the groups came in one category, and that was heart failure before day 7. So early recurrence of heart failure. These dogs were stabilized, and if they went back into failure in the first 7 days, they were excluded from the study. So if we look at these graphs and we exclude everybody else, what we see, 42% exclusions in the benazepril group versus 28%. And if we equalize those, we find then that there were 14% exclusions greater in the benazepril group. That may just be an explanation for the exclusions, and there is no more, but we wondered, could this possibly signify an endpoint difference? Was early onset heart failure different between the groups? And we'll come back to that in results. Gender between studies was approximately equal, males slightly overrepresented, 90% were neutered or spayed, 44 breeds, including 25% mixed breeds, and the Cavalier King Charles Spaniel and some other breeds, but notably Cavaliers were about 10%, which is a nice number. These were equally distributed between study groups. The age was a good targeted age, a mean of 11 years of age, with a range up to 19, and the majority, 2/3, were over 10 years of age. Body weight, as you'd expect, was an average of 20 pounds or 8.6 kilos, and the vast majority were under 25 pounds. There were concomitant medications and conditions that I'd like to address with you. These were senior dogs, obviously, so they had skin problems, ear problems, ocular problems, general health issues such as chemistry abnormalities, obesity, polyuria, polydipsia. So there were a lot of things going on, but they were typical of the senior population and not different between groups. Concomitant medications, routine like vaccinations, parasiticides were not different between groups and not unexpected. Of interest, however, specifically to us was the number of dogs which were on cough suppressants and antibacterials. And the reason for this is it is certainly apparent to all of us that some of these dogs have concurrent respiratory disease, and in some instances, this respiratory disease could be confused with heart failure. These were all looked at by specialists. I believe that wasn't the case, but we thought we could maybe help to show this by looking at this. And you see there was no difference in the number of CARDALIS or benazepril dogs in terms of those on cough suppressants in their history or antibacterials. They were virtually identical. And then lastly, what about prior cardiac medications? As expected, the majority received furosemide. The reason that this is 85 and not 100% is that some dogs went into failure and went directly into the study, so they had no Lasix prior to entering the study. 39% received an ACE inhibitor and 23% received pimobendan. You'll see the actual distribution of that momentarily. So 86% of the dogs received medications between day minus 30 and day 0, and about 14% went directly into the BEST trial without cardiac meds. So I'm going to run through the characteristics of the populations relatively quickly. And what we see here is a group of things, some of which I've mentioned, but you can see that the numbers are basically identical for age, body weight, gender, breed distribution, and severity of cardiac disease. 95% of the dogs were ISAC 1B or 2, and 100% of the dogs were in ACVIM stage C. What about their scoring? The clinical scores and pulmonary edema scores were virtually identical. So that includes clinical scores, appetite, cough, dyspnea, exercise intolerance, and syncope. And the reason that some of them had a pulmonary edema score of 1 or had no edema is because they were cleared during that first 10 days of pre-entry treatment. The treatments are shown for you here. We've gone through this pretty much. I just want to point out about pimobendan here. Pimobendan was given with ACE inhibitors. It was given with ACE inhibitors and spironolactone. It was given alone, and it was given with it was never given with just spironolactone. But you can see that these numbers are basically identical between groups, so no difference there. FETCH score, median FETCH score at entry was virtually identical, as were radiographic, echocardiographic, ECG parameters, serum chemistries, and notably creatinine, BUN, and potassium levels were identical between the groups, as was the urinalysis. So no differences statistically or by observation here. So as someone who was involved in this early on, it's gratifying to see that the randomization turned out so well. The target population was well represented by the study population, and there was equality between the two groups being tested. Males were slightly greater than females. They were 10-year-old dogs, approximately small breed, and in ACVIM stage C. None were refractory or stage D. Okay, so what about the efficacy results? This is where I think we will have the most interest, and I am just emphasizing we'll have some time for question and answers afterwards. The number of dogs reaching the cardiac endpoint was our primary endpoint. Secondary endpoints were number of dogs reaching the cardiac endpoint by visit, the time to the cardiac endpoint, and time to cardiac death or euthanasia. Some things that did not appear in the Freedom of Information Act, because we added these analyses later, and you should know they were not in the original design, were the number of dogs with heart failure recurrence in the first 7 days, the proportion of dogs dying or which were euthanized for cardiac disease progression, and time to all-cause withdrawal from the study. So here is the major point of this presentation, I guess, and this is the primary endpoint, the number of dogs reaching that endpoint at day 360. Of 414 dogs, you can see that only 78 of the CARDALIS dogs reached the endpoint, where 86% of the control group reached the endpoint, with a p-value of 0.0325. I've chosen to show this to you in a slightly different way. This shows you the percentage of dogs surviving to the end of the study without being removed. So they didn't have recurrence of failure, they didn't die. And you can see that there's a fairly dramatic difference here. This is about a 40% difference at 1 year when we compare it this way, sort of a glass half full look at things. And so all of this benefit is accrued by treatment with CARDALIS in terms of the endpoint at day 360. Another important endpoint, a secondary endpoint, number 1, is the number reaching that endpoint by study date. And we can see then that at baseline, there's no difference between CARDALIS in orange, benazepril in gray, with a p-value that's not significant. But after that point, starting at day 90, it remains significant, as can be seen by the asterisks over the gray bars of the benazepril group. So what I want to emphasize is that this occurred early, within the first 90 days, and it persisted throughout the study, this benefit. I'd also just like to emphasize something that I'll show you in the next slide, is that that benefit did not occur at 90 days, but somewhere between. And you'll see that it looks as though it occurred much closer to 30 days than it did to 90 days. And I think that's really important. I think it argues for getting dogs on CARDALIS early in the disease course. That's something I've argued for years. The benefits are early, and we should not delay instituting the drug. Personal editorial there. So looking at the endpoint number 2 as a secondary endpoint, how long did it take them to reach it? And what we see here is that the difference was between them, the groups was 103 versus 73, or a difference of 30 days. This is statistically significant, highly significant difference. And what I want to point out here is a couple of extra things. One is that at day 25, there is no difference between the groups, and probably not at day 30 either. There certainly wasn't significant. But when you get out to day 50, these groups have started to separate really nicely. I don't know that it's significant at day 50, that wasn't analyzed, but it is clearly separating. And this tells me that this separation occurs early. By day 90, we know that it was statistically significant. That's about right. That difference is significant. The last thing I want to show you from this graph is something I try to emphasize every time I look at a Kaplan-Meier curve, and that's that if we evaluate that curve up here at the 87th percentile, there's clearly no benefit. So if we want to know if there's a benefit that saves lives in the first week, we can't say that's true. If we drop down to the 50th percentile, we know that it's statistically significant, and this is what we're used to looking at. When we look at survival curves, we look at the curve, we take one number away, and we talk about that. And that's probably the right thing to do. But there is a subtlety, and that's that if we look at the 25th percentile, as is shown for you here, and what you see is when you use the 25th percentile, the difference between the control group and the treatment group is now 6 months. So for 25% of the dogs entering this study, they have a 6 months benefit in reaching the endpoint. That's substantial in the life of an 11-year-old dog with heart failure. And that's not just for this study, that's for any study. And then the time to that endpoint was affected by a number of things, but I want to point out that the odds ratio for treatment, CARDALIS versus benazepril, reduced rate by 0.71, or there was a 29% reduction in risk of dying or worsening heart failure in the first 360 days. BUN negatively affected this, PET score negatively affected this, atrial and ventricular dimensions negatively affected this, as did the furosemide dosage at entry. Gender had a sparing effect, with females being better off. And the third secondary endpoint is time to cardiac death or euthanasia, and we see that there was a statistically significant benefit here, and that the risk of dying for cardiac disease is reduced by half if they are on CARDALIS, as opposed to benazepril alone plus standard therapy. The post-hoc endpoints that most interested me was this early heart failure recurrence. So despite us showing that there is no benefit early on, remember that dogs who went out in the first 7 days were not considered in the analysis of survival or time to endpoints, etc. So of 569 dogs, almost twice as many dogs were, as a percentage, on benazepril went out due to heart failure recurrence in the first 7 days. This was statistically significant, even though numbers are small. And we see here then that at CARDALIS versus benazepril has a pretty dramatic effect on the return to heart failure in the first 7 days. The proportion experiencing cardiac death or euthanasia is shown for you here. Again, small numbers. This failed to reach statistical significance. I wanted to show this so out of transparency and the fact that I think there's a pretty strong tendency here for the drug to reduce the proportion of dogs experiencing cardiac death in addition to delaying the time to it. And for this, I'm going to take a deeper dive into looking at the cause of death and put just another more subtle point here. So, not surprisingly, in this population of dogs, cardiac death accounted for 86% of all deaths. And if you look, you see that sudden death was not common. In fact, it was quite uncommon. But out of 559 dogs, 16 died in CARDALIS group, 8 in the vonazepro group. This was 5.6%, was statistically significantly greater for the CARDALIS group. The rest of the dogs went out due to death from cardiac causes or euthanasia or worsening for cardiac cause, and then there were the non-cardiac deaths. So I want to look at the percent of all deaths here with you. And what I'd like to do is compare sudden death to death due to heart failure, which I'm including then in that this two groups of drugs as was divided out by the FDA. And when we look at that, what we see is that 22 dogs died of heart failure in the CARDALIS group, while 40 dogs died of heart failure in the vonazepro group. So that's 50% versus 71%, and that is statistically significant. So death due to heart failure was significantly greater in the dogs which received vonazepro without spironolactone with it. And then lastly, time to all-cause withdrawal. And what we see here is that there was a pretty highly significant difference between groups, with CARDALIS having fewer withdrawals, and we see that all causes, PUN elevation, heart rate, left atrium to aortic ratio, left ventricular dimension, chloride levels, vertebral heart scores, and furosemide, all of which were significant and contributed to this as a reason for withdrawal. Not worse in the CARDALIS group for sure, in fact better. So the safety then obviously important in a study like this, particular emphasis to renal function and potassium levels. And the adverse event and serious adverse event as defined by the FDA, and I'm not saying it isn't appropriate, but they're not the way that we would define them as clinicians. So their definition is any observation unfavorable and unintended occurring after the use of a veterinary product or investigational veterinary product, whether or not it's considered to be product related. This is an adverse event. Serious adverse event is a fatal, life-threatening, or one that requires professional intervention, again, associated with the product, but not necessarily caused by the product. So this shows you a summary. I don't want to spend a lot of time here, but I want to just point out that as judged by the FDA and the scientists at CEVA, dogs that had at least one treatment-related adverse event was pretty small, 45 out of 559 in the CARDALIS group versus 34. Certainly not different significantly. And then serious events, pretty common in these old dogs. Serious events occurred, but those that were thought to be treatment-related were surprisingly small and identical between groups. I think that point is worth mentioning. It speaks to the safety of both RAS suppressant therapy overall, and in particular for our efforts today, CARDALIS. And then death or euthanasia due to treatment-related events was virtually zero, 1 and 2 out of 559. So no significant differences between groups. Important. Looking at the adverse events, we'll look at the percentages here. You can ignore the rest of it, just what I show you in orange and in gray for the vonazepro group. And we see that there were no differences. In fact, these are almost identical. The one statistically significant difference is vomiting, more frequent with CARDALIS. Dyspnea, anorexia, cough vomiting, exercise intolerance, lethargy, and diarrhea were virtually identical with the exception of vomiting. These are the top 7 most reported adverse events. They're typical of signs associated with heart failure and older dogs. So aging cardiac patients, there's nothing of surprise here. Taking it a little deeper though, what about all the adverse events that occurred in more than 5% of the population? Obviously a bigger number, which includes the ones we already mentioned. Again, only one, vomiting, was more significant. Notable were exercise intolerance, renal insufficiency, and urinary incontinence, which were not significantly different, but were numerically a little bit different, and are also things that might interest you. And you can see the numbers here. So for exercise intolerance, 66 versus 50, that's not very eye-popping. Renal insufficiency, 31 through 19, we'll go into that in more depth in a moment. And urinary incontinence was more frequent actually in the control benazepril group at 2.3%, or excuse me, in 9.9% of the dogs versus 5.6% of the dogs. Okay, so one of the things that you're most interested in, that I was most interested in, was serum potassium levels. And we would expect that the addition of an MRA, be it spironolactone or eplerenone, would cause higher potassium levels. And that's borne out. And this is a box and whiskers graph that you're used to, with median shown by the line. The boxes show the 75th and 25th quartiles, and then the range is shown with the whiskers. This is a little bit different though, because beyond the whiskers are things that were considered to be statistical outliers. I'm not sure this adds anything, but you can see that even though the range shown by the traditional bar and whiskers, a box and whiskers graph here, in this group of benazepril dogs, here's a dog that had about an 8.3, 8.4 potassium level. This is very heartening. The normal range is shown for you for each of these graphs over to the right and by the dashed lines. So the median levels are identical, even a little higher than at day 90 for benazepril. Medians never go out of the normal range, never come close to going out of the normal range. And then sometimes it's actually lower, and again higher at day 360. So I still was interested, because of these outliers, to go just a little bit further with this. And so with the help of Dr. Kaufman, we explored all dogs that had a potassium level of greater than 6. Before that, of the adverse events approved by the FDA, there were only 4 due to hyperkalemia. And all of these were in the CARDALIS group, but only 1 dog was removed from the study. And I can tell you that looking at that 1 dog, it developed a potassium level of 6.3 on one day and was removed from the study. I'm not saying that it shouldn't have been. It certainly is something to be aware of, but you'll see in a moment that most dogs have, when they have an elevation, it doesn't stay elevated. A very small percentage of the dogs in the study had potassium levels greater than 6, 0.035%. So that is, obviously less than 1%. Or just around 1%. No, less than 1%. Decimal points were never my strong point. Of these, only 1 dog in each group was a clinical adverse event, one that you as a clinician would say, yep, that's an adverse event. All others were one and done, where the level went above 6 for 1 time only. So pretty gratifying about potassium. Got to be watched, should be watched. Be wrong not to watch it. Renal function would be the other thing you'd be interested in. And you can see, looking at the box and whiskers graph, that there are tons of azotemic dogs early on. They remain throughout the whole study. That's part of doing business with diuretics, part of heart failure. And you can see, however, that the BUN never rises above the normal range based on the median. And it is oftentimes virtually equal although it does rise in the benazepril group at day 360. If you look at creatinine, which is a little more reliable, although certainly imperfect, we see that, again, the medians never go above the reference range here of creatinine, and the only significant finding in all the renal evaluations was that serum creatinine was significantly lower at day 90 in the benazepril group. And then it was higher again at day 360. So again, this is pretty gratifying. As always, renal function should be watched in heart failure patients, particularly if they're on high doses of Lasix, particularly if they are on RAS suppressant drugs. So our safety summary is that 5 of the top 7 adverse events were expected in aging dogs with heart failure: lethargy, cough, anorexia, dyspnea, exercise intolerance, and were baseline characteristics of the population at day 0, meaning they were pre-existing abnormalities. Vomiting and diarrhea were the top 2, and these are commonly seen with the administration of oral drugs in all studies. There was no significant difference between groups in occurrence of adverse events or serious adverse events. And that's really saying something, and it backs up or is backed up by the pharmacovigilance data from Europe. After 76.5 million doses have been prescribed, adverse events reports are really rare, 0.01%, or 1 in 1,000 to 1 in 10,000. So we can conclude, and this is what's on the Freedom of Information Act, is that CARDALIS is safe and effective when used with concurrent therapy, in this case diuretic, for the management of clinical signs of mild, moderate, or severe heart failure in dogs due to left-sided valvular disease. And I would just add my own personal editorial comment to that. It's not just management of the clinical signs, because RAS suppression has very positive effects on remodeling, and which can contribute to improved survival. So discussion, brief, but if we look at all the endpoints, we see that the primary endpoint was met nicely with CARDALIS. The percentage reaching the primary endpoint by visit occurred persistently and early. The time to the cardiac endpoint was prolonged significantly, particularly so for the last 25% of the dogs remaining in the study. The baseline population with early heart failure recurrence was significantly greater in the benazepril group. The percent death, cardiac death, was greater but did not reach significance in the benazepril group. However, when you looked at all causes of heart failure, meaning euthanasia and death versus sudden cardiac death, it was significantly greater. And then we have time to cardiac death or euthanasia took significantly longer. So a nice group of signs, very gratifying to see. I wanted to show the data of the BEST trial in comparison to the landmark RALS study carried out by Bertram Pitt, published in 1999, in which standard therapy plus spironolactone, which at that time was an inexpensive passé diuretic, weak diuretic, versus standard therapy plus placebo. They showed the difference in failure of all causes was 11% for the RALS. It was 8.6% here, so very comparable. Reduced mortality, 30% for RALS, 36% for BEST, again, very comparable. So the BEST study stands shoulder to shoulder with the RALS trial as a landmark study for the management of heart failure in dogs. The conclusion then, CARDALIS is superior to benazepril alone, along with standard therapy, with significantly fewer dogs reaching the end. CARDALIS delays the time to cardiac endpoint, including cardiac death, as compared to benazepril without spironolactone. CARDALIS is well tolerated Most of the adverse events are those that are expected with an aging population with heart failure, and the post-market data in Europe show that adverse events are exceedingly rare.